my nutshell of my thesis, as you see in the slide, this thesis was guided by our honorary Professor Carl Theodore. So let me move on. The structure of my presentation is going to be, I'm going to introduce you to healthcare costs and population health benefits, and what is the concept of value of healthcare, cost effectiveness analysis, and what we did in Trinidad and Tobago, what is the inference of the study, what recommendations we have, and a summary. And this is a very familiar slide to many of you. This one shows the longevity, the life expectancy in the OECD states, and you can see that the per capita healthcare spending has nothing to do with longevity. So you see the US has $8,000, Trinidad $900 US dollars, and I have given there India and Ethiopia just for comparison. Now, what are the drivers of these costs? The first thing is moral hazard. As you all know as economic students, in standard economic theory, moral hazard is when you venture into something when you know for sure that the risk is not taken by you, is taken by somebody else. So that is what is proposed as a primary driver for healthcare costs. Then the diffusion of high technology. Then we do have this problem of asymmetry of information. As clinicians, we tell you something. As patients on the other side of the table, you don't know. You have to just trust us that, this is what is needed. MRI is needed? Yes, okay, I'll go ahead for it. And same way, that the consumer, the patient is paying for the product as well as the service. And the demand is not necessarily created by the consumer, and we create it. Other reasons are political and socio-economic dimensions. We model the healthcare system following other countries, and there is always this industry and technocratic push. Now, this is a very interesting slide from WHO. If you see over centuries, the gain in life expectancy, standard of life and other personal hygiene measures increase the longevity until around, you can see here, around 1990. After that, it just slowed down. This was average life expectancy increase from 1960 to 1990 when we invented all the vaccines and stuff. Now, after 1990, you have this high technology, medicine, intensive care, everything, but we just gained just 1.7 years. So what this translates? Now, gain in life years, at that particular first 1960 to 2000 was 5, the increase in cost was like 15%. And this is a very conservative estimate, global estimate. And this for this 2000 onwards, we have at least 55% increase in the healthcare costs. So that brings us to the concept of value. Value is quality over the costs. High quality healthcare with minimal cost is what is of the best value. A gimmick is something which gains to give you good health, but it costs more and gives less benefit. This is a very familiar diagram you will have. This originated from one of our papers here, Barbados and Trinidad. See, for the same outcomes in intensive care, so you can see the difference in the costs. So the costs need not necessarily translate into high quality healthcare. So the pertinent questions we have is higher healthcare expenditure. Is it synonymous with better outcomes? Has highly expensive technology, high technology medicine has improved the social health index? And what are the factors which influence the access? Is it the socioeconomic status, geographic location, willingness to pay? There's so many things to ask. So with this background, we did we embarked on this cost effectiveness analysis, and we took the cardiovascular illnesses as an example. So you all know that cost effectiveness is opting between an alternative intervention. You can see whether a new antiplatelet drug is giving more health benefits than one more coronary angioplasty. So what we have to do at the end of the cost effectiveness analysis is to have a cost effectiveness ratio, which is the numerator is the cost and the denominator is health outcome. So the objectives of my study was to conduct a cost effectiveness analysis. We estimate the cost of different levels of healthcare, and we estimated the outcomes applying disability adjusted life years. So what we did is we did for primary care, ICU care, and high technology care. So this is the methodology I followed, the steps of conducting the cost effectiveness. We clearly specified the patient group. We estimated the cost. We identified and measured the relevant outcomes. And then we did a sensitivity analysis to account for the uncertainty. Now, the patient groups, as I told you, the example was cardiovascular illnesses. So from the Central Statistical Office, we took this ICD codes I00 to I99, and morbidity and mortality data was extracted from CSO, Ministry of Health, as well as from regional health authorities. The cost of interventions for these three areas, primary care centers, ICU care, and angioplasty, was estimated. I used a top-down, which is a cost block model, which was developed in the UK for ICU cost estimation. And as I told you, the outcomes actually was disability adjusted life years. This is the years of life lost due to premature death, as well as years of life lived with disability. So this is something which is lost and not gained. I mean, Henry presented EQ, 5D, and QALYs. QALYs is something to be gained. DALYs are something which are lost, which an intervention has to avert. So this is a population outcome measure. We took 2006 as a baseline year because we did a cost estimation of ICU that year. And then we got the data from CSO. We used a MATLAB program to actually calculate the DALYs. These are my results. You know, this is a cost block model which we use. We use a primary healthcare cost. This is the first time we used a cost block model for a primary healthcare center. We did it for ICUs. And then this is these are my results actually. For primary care, in 2006, around 28,000 patients accessed primary care centers. The cost was in international dollars, 236,000. For a Trinidad conversion, it's almost like 4.8, so you could multiply by 5. ICU care costed around 700,000 international dollars, and the angioplasty and coronary artery surgery costed 3 million international dollars. That's 15 million TT dollars. Now, the DALYs can be calculated according to ideal longevity or TNT longevity. For this particular cost effectiveness analysis, we have to do the local longevity, which is 69 years for male and 75 for female. So the total DALYs we got was 9,778. The DALYs are calculated by WHO. It's all in the net, but we did it from scratch. We didn't extract the WHO DALYs. Now, this is the most interesting part of it. When we calculated the DALYs by different interventions using the proportion of patients accessing that type of intervention, you can see that 2,000 was for the primary care, ICU care is 21, and angioplasty is just 8 per 100,000 population. So the cost effectiveness ratio will now actually get reversed like that. So the best cost effectiveness is with primary care. Angioplasty has 444,000, which is way ahead of the threshold given by WHO. And then we did a sensitivity analysis to just make sure that the assumptions did not influence it, and it just showed that there was no overlap. So we are, even though we had assumptions in cost estimation, we are good. So this is a one-way sensitivity analysis by bootstrapping. So what are the findings of the study? To avert deaths and disabilities due to cardiovascular illnesses in Trinidad and Tobago, a relatively smaller amount is spent in primary health care, 3 times the money in ICU care, more than 10 times for coronary artery bypass surgery. And DALYs avert, DALYs averted is best by the primary care. So the inference is that resource allocation should be focused towards primary care intervention to get population benefits. This does not imply, again I have to tell you, the Oregon model, they use the cost effectiveness analysis to cut down the budget for other things. I am not advocating that. I am just saying that, you know, allocating funding for new ICUs and angioplasty centers will not give the same as for primary care. That's my inference. So what happens in TNT about funding of the healthcare? It's predominantly public funded. Policy decision makers do not have evidence-based guidelines. It's based on request, or they just imagine that this is what has to be done. So this is the example in 2012. This is one of the RHAs. You can see tertiary care got 80%, 79%. And primary care cluster, 8, 6, and 3. And their head office even got the same as one primary care cluster. So that is the type of allocation. This is real data from the RHA. So why tertiary care is getting priority? It brings profit in the private setting. It brings mileage and credentials in the public setting. And we know that ministry is now in the expansion mode, and health minister announced, but I have to confess that this is a previous health minister. So it's 2 billion to spend 3 hospitals. So there is a cultural change. Specialist consultations far exceed and the primary care. So it's much more in the elderly. So this is the major contributor for the cost. This is from the US, okay? In 2004, you can see the difference in the income between primary care practitioners and the gastroenterologists, more than 200%. Cardiologists, 253% of what primary care practitioners earn. Radiologists, 260%. And it is, during the same time, there was 10% reduction in the income of the primary care physicians. So who wants to take it? What happens in US? There's enough evidence. All health economists and social scientists say that the rising healthcare costs and lower gain in the social outcomes in US is due to the decades-long decline in the primary care system. And you see that in 2009, 750 billion was wasted due to unnecessary procedures, inefficient services, and fraud. This came out of Institute of Medicine. So why do we have to follow the failed system? Why we have to prioritize tertiary system? You know, this can reach the same state what US has reached now, unavoidable cost escalation. So what I feel is not only the patient should have a preventive care, even the health system should have a preventive care before it goes into this cost escalation. And we need a very strong political will to address this situation. So we need to have something called the health technology assessment, which is social, political, economical, and legal, ethical consequences of introducing new technologies into medicine and healthcare. And we need to use incentives to use the appropriate technology and disincentives to curb the unnecessary use of technology. I have to admit there are some limitations to my study. The cost estimation has inaccuracies. DALIs have extensive data requirement. And this morning, Sir George very eloquently put that, you know, academics should not be arrogant in just presenting the data and expect politicians, because their utility functions can be different. I fully agree with that, but on the converse, politicians cannot be arrogant also. You know, I mean, if we, you know, we don't have something like this type of a politician in our country, but, you know, it's only a matter of time before somebody can make a decision that I don't care about your qualis and EQ 50 and, you know, ED 50 or DALIs. I will do whatever I want. So that is that, you know, with all our data, I don't think we will be able to implement until Professor Theodore gets into the advisory board. So what are the messages? So we have to go back to our basics, strengthen the primary care, and regulate the care provided in the ICU as well as in coronary artery bypass. I'll tell you a secret. Most of the coronary artery bypass surgeries done in this country are unwanted, or they can do well without that. That's all I will say. So we have to educate the society and population. Everybody thinks that, oh, if I get a bypass surgery, I'll be walking around, I can go to space. That is not true. So that brings an end to my presentation. And if we can actually, with simple cost measures, you know, treat something like that, directly observed therapy, why do we want to go and robotic surgery? I spoke to the persons who introduced robotic surgery in Canada. And they want to just take it away because it is not cost effective for them. And we want to bring in robotic surgery because I don't know why. So that brings the end to my presentation. Thank you for listening.